Hello everybody. Today we are going to discuss about the advanced mode of ventilation. So volume assured pressure support ventilation. Volume assured pressure support ventilation. It is the dual mode of mechanical ventilation that associates pressure support ventilation to volume assisted ventilation. This combination optimizes the inspiratory flow, decreasing the patient's work of breathing while assuring the set tidal volume. Compared to the volume assisted ventilation, volume assured pressure support ventilation can decrease the patient's respiratory drive and pressure time product and the patient's work of breathing. This advanced mode of ventilation extends the benefit of pressure support ventilation to unstable patient with acute respiratory failure, assuring preset tidal volume. This is the pictorial representation of volume assisted ventilation, which is compared to the pressure support ventilation. Now the next is proportional assisted ventilation. Proportional mode deliver assistance in proportion to the patient's demand, allowing variation of inspiratory pressure and avoiding diaphragm, excessive loading and atrophy by disease. Proportional assist ventilation is a form of synchronized ventilator support in which patients generate pressure in proportion to the instantaneous patient effort and in proportion to the flow and the volume generated by the same. Therefore, ventilator allows at any time during inspiration airway pressure in proportion to the pressure generated by inspiratory muscle and respiratory mechanics. Initially described by Magdalens in 1992, proportional assisted ventilation amplifies inspiratory effort with the goal of patient comfortably attain whatever ventilation and breathing pattern that control system desire. There is no target tidal volume and mandatory rate and airway pressure preset. So ventilator is able to automatically adapt to changes in the ventilator demand of the patient. The pressure delivered by the ventilator following inspiratory muscle pressure profile, usually with progressive increase from the beginning of the inspiration with gradual pressurization to the end of inspiration. Maximal assistance is achieved until the end of inspiration. Unlike PSV, in which constant preset level of pressure assist each inspiration, regardless of patient's inspiratory effort, proportion assisted ventilation allows assistance proportion to the patient's demand, avoiding under assistance and over assistance frequently observed during pressure support ventilation. Under assistance can induce respiratory distress, and over assistance can cause over distension, and both may generate patient ventilator asynchrony that are associated with poor outcome. Therefore, proportional assisted ventilation is designed for patients with stable respiratory drive and can be used in any patient who is being ventilated under pressure support ventilation and during weaning from the ventilator mechanical ventilation. So the proportional assisted ventilation is also designed to improve synchronism while generating proportional assistance. Limitation, advantages, and current evidence of proportional assisted ventilation. Proportional assisted ventilation can also be used during an IV. So, proportional assisted ventilation requires clinical estimation of resistance and elastance and measurement of these criteria with the short end inspiratory occlusion cannot be accurately performed in presence of leak, and it can, however, be of limited reliability. Therefore, proportional assisted ventilation as NIV did not present in any evidence for the daily routine. So, synchronism and proportional assistance, work of breathing monitoring, seem to be the main advantage of PAV as well as to improve patient ventilator synchrony. Several studies and reviews evaluated PAV in comparison to PSV, showing results favorable to PAV regarding synchronism, weaning success, sleep quality, duration of mechanical ventilation, lung and diaphragm protection, lower proportion of patient requiring reintubation. Although mortality seemed to be generally favorable with PAV, this hypothesis has not been confirmed and more studies are necessary for this issue. One systemic review and meta-analysis that evaluated 14 randomized control study involving 931 patients showed no difference on intubation risk, weaning time, hospital mortality, reintubation, or tracheostomy. Now the next is neurally adjusted ventilatory assistance, that is NAVA. NAVA is a mode of mechanical ventilation delivering pressure in response to patient's respiratory drive measured by electrical activity of the diaphragm. It is initially described in 1999 by Christer Sindrell et al. And it introduces new dimension to mechanical ventilation in which patient's respiratory center can assume full control of magnitude and timing of the pressure support provided. Regardless of changes in the respiratory drive, this technology helps to decrease the risk of hyperventilation, respiratory alkalosis, and hemodynamic impairment. NAVA captures the electrical activity of diaphragm and uses it to assist patient breathing in synchrony with and in proportion to the respiratory drive. So normal electrical activity of diaphragm generally ranges between few and 10 mu volt, while patient with chronic respiratory insufficiency may demonstrate signals 5 to 7 times stronger. Although there is no cutoff for weaning outcome, electrical activity of diaphragm about 26 volt can relate to the failure. Like proportional assisted ventilation, there are no target tidal volume, mandatory rate, and airway pressure set. Ventilatory support is the proportional to the combination of electrical activity of diaphragm and NAVA level, which defines the magnitude of pressure delivered for a given electrical activity of diaphragm. So NAVA depends on captured signal of electrical activity of diaphragm via sensing electrode on nasogastric tube, so that in case of damage to phrenic nerve or alteration on its activity, NAVA cannot be used. Therefore, NAVA, like proportional assisted ventilation, is also designed for patients with stable respiratory drive and can be used in patients who are ventilated on PSV or during weaning from mechanical ventilation. So NAVA is also designed to improve synchronism while generating proportional assistance to electrical activity to the diaphragm. This is the pictorial representation of NAVA. Limitation, advantages, and current evidence of NAVA. Limitation of NAVA mode is that it requires specialized nasogastric feeding catheter with electrode located in the esophagus for its functioning, which add additional cost. The advantage of NAVA mode are that it can monitor electrical activity of diaphragm, it improves inspiratory and expiratory synchrony, and it can be used as non-invasive ventilation mode too. Since electrical activity of diaphragm is pneumatically independent signal and is not affected by leaks, NAVA can deliver assisted synchrony during NIV even with leaks. Only few larger studies compare NIV NAVA with NIV PS pressure support. No clear improved clinical outcome were observed except a decreased incidence of asynchrony in NIV NAVA. A large multicenter randomized control clinical trial that included patients with acute respiratory failure from several etiologies. NAVA was used in 153 patients with while another 153 enrolled in the control group used volume control ventilation, pressure support, pressure control ventilation, PSV, and pressure regulated volume control. So NAVA decreases the duration of mechanical ventilation, although it did not improve survival in ventilated patients with ARF. Now the next is adaptive supported ventilation. Adaptive support ventilation is the closed loop control ventilatory mode which is designed to ensure optimization of patient work of breathing, automatically adjusted according to the patient's requirement. ASV combines passive ventilation with pressure control ventilation with adaptive pressure support if the patient's respiratory effort is present. ASV delivers the pressure control breath according to the set minute ventilation, resulting in the best combination of tidal volume and respiratory rate. As the patient's inspiratory efforts start, ASV delivers the pressure supported breath according to the set minute ventilation, resulting in the best combination of tidal volume, respiratory rate, and patient's inspiratory effort. In ASV mode, FiO2 and PEEP are set manually. Now the IntelliVent is. IntelliVent ASV is also closed loop ventilation that adds monitoring of SpO2 and pressure in tidal CO2 to best manage ventilation and oxygenation. The IntelliVent ASV mode, the clinician sets the patient's sex, height, and choice the following respiratory mechanics situation: normal, ARDS, chronic hypercapnia, and brain injury. IntelliVent ASV determines the target EtCO2 and SpO2 according to the patient's condition. The ventilator controller adjusts the best tidal volume and respiratory rate to achieve minute ventilation and EtCO2 set by clinician combining pressure control and pressure support ventilation according to the patient's inspiratory effort. In IntelliVent ASV, FiO2 and PEEP are adjusted according to the patient's SpO2 following PEEP FiO2 table. Now, smart care ventilation, it is the automatic weaning protocol designed to stabilize patient's spontaneous breathing in comfort zone of present defined ventilation and to automatically reduce ventilatory support. This it ventilates the patient with pressure support, which levels are adjusted according to the respiratory rate, tidal volume, and tidal CO2 to meet patient's demand. It classifies the patient minimum of every 5 minutes into one of 8 categories and decreases the increased pressure support level accordingly. It assesses and indicates the readiness of extubation after successful automatic spontaneous breathing trial. Now about conclusion, volume assured pressure support ventilation can guarantee tidal volume with advantage of pressure support variable inspiratory flow. Proportion assisted ventilation plus can monitor the patient's respiratory compliance, respiratory resistance, auto PEEP, work of breathing, decreasing the patient's ventilator asynchrony in comparison to PSV and other ventilator mode. PA proportion assisted ventilation plus allow lung and diaphragm protection, avoiding under and over assistance. NAVA allows the measurement of patient's diaphragmatic electroactivity, and NAVA mode decreases the patient ventilator inspiratory expiratory asynchrony. ASV adjusts the pressure support according to the respiratory rate to maintain preset minute ventilation. IntelliVent ASV adds monitoring of PtCO2 and SpO2 and adjusts the pressure support according to respiratory rate to maintain minute ventilation according to lung pathology. Smart care ventilation can automatically wean the patient according to the distinct patient classification of lung pathology and indicates readiness of extubation. Thank you, guys.